Hello, thank you for participating in my gender affirming care intervention that we will have in order for me to complete my DMP project. The topic that we will be addressing is regarding the gender affirming care when titles mislead. My name is Brad Sweatt. I work with many of you on a pretty regular basis, and you know that we have taken on the additional role of uh, working with Dr. Finster regarding transgender patients and a lot of gender affirming care and procedures as well. There has been a little bit of consternation that has been among some of the staff members regarding this at all levels. And I just wanted to take this opportunity to maybe address some of the reasons why we use some of the vernacular and vocabulary that we do when addressing these patients in order to provide them the most optimal experiences regarding our healthcare visit. To begin, we'll first address our objectives, and the very first thing we will address is the vocabulary in order to get to a shared language so that we understand the backgrounds from which our patients are coming from and the vernacular in which they wish to be addressed in a respectful manner. This will also provide cultural humility and strength-based interviews as reminders to the providers. We also will need to look for the needs of the gender expansive people in engaging in care. I will also address the unique opportunities and the gaps for data collection so that we can become better providers, giving us unique opportunities, of course. And then we also want to understand how to provide healthcare to LGBT patients in ways that acknowledge the social determinants of health. So to begin, I want you to look at that symbol that's on the left side of your screen. Where are these symbols typically seen? Bathrooms. It's totally how we've been told to see gender. And especially for those of us who grew up in the United States, we're very familiar with seeing man wearing the pants and women wearing the dresses on these type of signs. However, gender is not necessarily static for everyone. These bodies would all look very different and they would move around on a spectrum, more like what you see at the bottom right side of your screen. Doesn't necessarily mean that a man that is wearing feminine clothing or dresses even means that they are gay or straight. It just simply implies an expression of who they feel as an individual. And this is a biggest portion of consternation that a lot of people have had, is that they misconstrue what gender identity is with sexual orientation. So what is the problem? Well, I want you to take the time to look at the illustration that's on your screen right now. I want you to spend a moment just noticing this photo. You'll notice that there are 3 different patients and there are 2 different clinicians. What do you think each of the individuals in this photo is thinking or feeling? What do you perceive them to be experiencing? And then I'd like you to ask yourself, what do trans individuals need when accessing care? When I first began this project, and more specifically developing this presentation, I worked with 3 different people that identify either as transgender or non-binary, just so that I had some type of cultural relevance to be able to provide insight rather than simply giving it from a perspective as a cisgender male. So one of the quotes that one of my consultants gave me was, "We need folks to see us, to affirm us, to believe us, to value us, to be respectful and offer care and consideration and privacy, and to learn about our needs. And of course, when you look at the photo above, the center individual is a patient who is identified as transgender, and you can see the apprehension that she has prior to even receiving care based on what the gender constructs have been before. Now, all of this is said before we even speak to the social determinants of health. But we'll go ahead and report back from the 2015 U.S. Trans Discrimination Survey that involved 28,000 respondents. So the problem is 1/3 of respondents on that survey who had seen a healthcare provider in the last year reported having at least one negative experience related to being transgender, such as having to teach the healthcare provider about transgender people to receive appropriate care, 24%. 15% report a healthcare provider asked them invasive or unnecessary questions about their transgender status that were not related to the reason for the visit. 8% report a healthcare provider refusing to even give them transition-related care. 6% said they were verbally harassed in a healthcare setting, such as a hospital, office, or clinic. 5% reported a healthcare provider used harsh or abusive language when treating them. 3% refused to care for them in a way that is not even related to their gender transition, such as physical or care for the flu or diabetes. 2% said that they were physically rough or abusive when treating them. And then you'll also see 1% of people also reported they were physically attacked by someone during a healthcare setting. They were sexually assaulted in a healthcare setting. And over in the past year, 23% of the respondents did not even see a doctor when they needed to because of fear of being mistreated as a transgender person, and 33% did not see a doctor because of the cost. So we obviously have a lot of health disparities that are associated with the stigmatization of the way they are treated in the office or in the hospital setting. Of course, this leads to a greater problem, and this is where stigma and discrimination can lead to a lot of stress and limit access to care. The daily and acute stress caused by these issues can impact an individual's mental and physical health. So can the lack of access to culturally competent care. When a population such as the LGBTQ people experience negative health impacts, we see health disparities in that population that are not seen in the general population as a whole. And as you can see up here, stigma and discrimination leads to chronic and acute stress, and that ends up leading to healthcare impacts such as mental health issues, physical health issues, access to the care, and access to competent care, which leads to health disparities and inequities. So there are organizational barriers that are out there that impact the LGBTQ community a lot more so than people that are heterosexual or identify within their cisgender bodies. And just to provide a little relevance, the discrimination is very common in the lives of LGBTQ plus individuals. And you'll see the statistics over here to the right as referenced by the U.S. Department of Health and Human Services from 2020. And among LGBTQ plus individuals, 39% have been rejected by a family member or friend, 30% have been threatened or physically attacked, 21% have been treated unfairly by an employer, 30% of youth have missed at least one day of school in the last month because they felt unsafe or uncomfortable. Regarding violence, transgender women, especially Black LGBTQ plus people, are much more vulnerable to violence. 46% of transgender Americans reported verbal harassment, 9% reported being physically attacked in the past year. And in healthcare, 25% of transgender patients report being harassed in a doctor's office, whereas 19% of transgender patients also report being denied medical care in the first place. Of course, there are other considerations also to consider that disproportionately impact the transgender population. From 2009 to 2014, over 2,300 transgender people were diagnosed with HIV in the United States. 84% of those were transgender women, 15% were transgender men, and approximately 1/4 of all transgender women today are living with HIV. Of that percentage, more than half of those are Black or African American transgender women. So new HIV diagnoses are 3 times the national average of other cohort groups such as cisgender males and females and other gay individuals as well. So 3 times the national average, letting you know that there's a greater impact of disparity among this group. Now we're going to branch off into a little bit of the terminology and vocabulary that's associated with this group. But before we begin that, as I had mentioned a little earlier in the program, it's very important to understand that sexual orientation does not equal gender identity. So let's do a review of sexual orientation terminology. We have asexuals who describe themselves as experiencing little or no sexual attraction to others. Asexuality is not the same as celibacy. Bisexual, a sexual orientation that describes a person who is emotionally and sexually attracted to people of their own gender and people of other genders. Gay, a sexual orientation that describes a person who is emotionally and sexually attracted to people of their own gender. It can be used regardless of gender identity, but it is more commonly used to describe men. Heterosexual, also known as straight, a sexual orientation that describes women who are emotionally and sexually attracted to men and men who are emotionally and sexually attracted to women. Lesbian, a sexual orientation that describes a woman who is emotionally and sexually attracted to other women. Men who have sex with other men and women who have sex with other women. This is a confusing category because it's a category that's often used in research and public health settings to collectively describe those who engage in same-sex sexual behavior, regardless of how they identify their sexual orientation. However, people rarely use the terms MSM or WSW to describe themselves for same-sex attractions. So a lot of people sometimes maybe not identify as particularly gay or straight for fear of social stigmatization. And it's a quick way to identify people who maybe just have a sexual attraction to other men who have sexual attraction to other men but don't identify as gay. It's slightly confusing, but basically it's used for research purposes only. That way, in order to collectively group the data together, rather than saying that this person identifies as gay and this one doesn't, and now we basically can't use the same qualifiers. You also have pansexual, and this is a sexual orientation that describes a person who is emotionally and sexually attracted to people regardless of their gender. So language changes all of the time, and there are some consistent definitions that I'd like us to be on the same page about. And this is going to be regarding the review of gender identity terminology as opposed to the sexual orientation terminology that I used on the prior slide. First of all, a person's birth sex. This is the phenotypical gender at birth. So if a child is born with a penis, their birth sex is identified as a male. If they are born with a vagina, their birth sex is identified as a female. And of course, there are some exceptions, such as with hermaphroditic uh, babies being born as well. I'd also like to identify gender identity and gender expression. Cisgender, that is where your gender identity matches with what your birth gender is. So if you were born a male and you identify as a male, you are considered cisgender. If you are born as a female and you identify as a female, then you are considered to be cisgender. In regards to transgender, the gender identity does not match with the birth gender. So therefore, if you were born as a male, but you have identified as a female, you are considered transgender. If you were born as a female, but identify as a man, then you are considered a transgender as well. And there's a third category as well, and that is non-binary, gender fluid, gender queer. This is where gender expression is fluid, with both stereotypically masculine and feminine traits being expressed, and it can change from day to day. It's just how they wake up and feel that day in order to be able to express how they feel. It doesn't change how they may perceive themselves. It's just how they wish to represent themselves in the way the world needs to identify them. You'll see those people as non-gender, gender fluid, and gender queer referring to themselves as they, them, their as their pronouns. Individuals just do not prescribe to one set gender. And then you have also gender expansive, which refers to words such as gender nonconforming. However, we're seeing that less and less because of the fact the word conforming indicates that it is a marginalized population. It's not a gender identity, but it just simply may be an expression of that gender. Gender affirmation is a term that is used for medical, social, and legal constructs simply because of the fact that we want to be able to affirm that we are identifying what they identify as and affirming that level of care that we provide them. So to me, it is no different than when I have a patient who is transgender and they may have a different name and than what their ascribed name is. And what I would like to do is say, my name is James Bradley Sweatt. I have never gone by James a day in my life. But if I were undergoing anesthesia, I would like people to address me by the name I wish to be called, which is Brad. I will go to sleep being called Brad, and I wake up much better being called Brad. No different than any other nickname. We simply look at these individuals as, hi, who are you? What do you wish to be called by? And leave it at that. It's a way of saying, I recognize you. I understand that you go by a different name, and I choose to call you by the name that you wish to go by. As I said, it's no different than a nickname, such as Bill for William, or even more so going on lines of calling somebody Spike or Junior. We are used to taking care of those patients daily like this. So therefore, it shouldn't be that difficult to be able to identify their gender based on what they wish to be called by. And if you treat it as such, it's a way of being able to respect and exhibit that cultural humility that we are all in this together. So on this slide, we're going to get into pronouns. He, she, they, WTF. Well, gender is not exclusively determined by an assigned sex at birth, but determined by a person's sense of belief, of ultimate expression of their self. He/him/his, these are people who identify as male. She, her, those are people that identify as female. They, them, their. These are people who identify as gender non-binary, gender fluid, or gender queer. And basically, it's easier to call them they, them, their because of the fact they're on a spectrum in which they express the way they feel. And this can be a very confusing and a source of contention among a lot of people, but it's like some days they wake up feeling more masculine or more feminine, and they use their actions and behaviors and clothing as an expression of how they feel. But for us as clinicians, the goal of treatment for transgender people is to improve their quality of life by facilitating their transition to a physical state that more closely represents who they identify as their sense of self. And to me, it is no different than somebody undergoing plastic surgery who needs fillers or a rhinoplasty in order to make them feel better about who they are or who best reflects who they are as a person. They have control over how they want to be able to express themselves to the world based on their decisions. Just like tattoos. These are things that people put on their bodies so that you can express to the world what you like, what you're into, hobbies, family members. It's a self-expression, and that's simply what our gender-affirming surgeries provide for these individuals. So when I was addressing one of our colleagues about what my project was going to be regarding, I was addressed with, but what if I don't know how a person identifies their appearance? And my answer is simply, it's okay to ask. The fact that you even acknowledge their right to express themselves often, it elicits a more open-ended conversation in that patient-provider relationship. Ask what names and pronouns they choose to be addressed by. And if you get it wrong, just simply apologize for a misstep and move on and try to incorporate it better. The goal of treatment for transgender people is to improve their quality of life by facilitating their transition to a physical state that more closely represents their sense of self. And if you keep telling yourself that and just ask and identify with the patients that are there, they will feel that you are coming from a much more respectful place. And of course, another key clue is do not assume anything. It is much better to be polite and ask the patient how they wish to be addressed rather than just assuming. And as I said, usually during this interview with the patient, you'll notice that they'll become a lot more open and respectful enough that you call them by their name, that they're willing to engage more in appropriate care and be more honest during the patient interview. And of course, there are a lot of outdated terminology and phrases out there. We don't refer to them as transgenders, transgendered, or a trans. Transgenderism is a term that has been outdated. Sex change is outdated. And we don't refer to an individual as pre or post-operative. We don't refer to trans people as biologic, genetic, born as a man, born as a woman. And of course, terms such as tranny, he, she, shim, transsexual, cross-dresser are also antiquated and also discriminatory phrasing. Real name gender, under quotes, preferred pronouns, under quotes, are also condescending. And you never say things such as, wow, you're so beautiful for a trans woman. Obviously, there's a state of disproportionate, you're not just a pretty woman, you've got to be beautiful for a trans woman. Simply don't address this type of phrase. And then if you refer to it as male-bodied or female-bodied, then you're also an outdated terminologist here as well. Now, this is not an exhaustive list, and someone may ask you to refrain from using a certain word to describe them, and it's important that we listen, because there are certain words that are now culturally acceptable that I personally don't feel acceptable in my own skin saying. And I say that because of the word queer. It's very common vernacular right now, but in my youth, that was a horrible derogatory term that had a lot of hate and discrimination behind it. But it's become more common now as a lot of LGBTQ individuals have adopted it as owning the discrimination from the past and taking a sense of power behind the word. However, I still don't feel comfortable if it is used to describe me. And remember, like I said, if they say please don't use that word, it's important that we listen and just apologize for it. It expresses that cultural humility we were discussing. And also, some of the words are in community words only, and these individuals have reclaimed the language for themselves, as I had mentioned regarding the word queer. And we have to remember that we as clinicians are all lifelong learners and culturally humble people, and we have to be committed to honoring people's identities and however they describe themselves. So this will segue into our other topic, which is going to be cultural competency versus cultural humility. And cultural competence is defined as the ability to work effectively with people from different cultural backgrounds. And this to me is simply a checklist of training that an organization has to have in order to meet a standard, saying that they're culturally competent and that their employees or individuals in an organization can work together and they have been trained effectively. However, working together with somebody does not necessarily honor exactly who that person is or where they come from, which is where cultural humility comes into effect. And I'll go into a little more about that shortly in the next slide. So what is cultural humility? Well, it's the lifelong learning and critical self-reflection where you take cultural competence and what you do know and have learned and being able to express it so that you recognize and challenge those power imbalances for respectful partnerships. It's a way of being able to look at a person and understand that they come from a different background, either due to race or due to their gender identity or sexual orientation. And it allows us to recognize and challenge these power imbalances so that we can have that respectful partnership with our coworkers or friends, individuals in the community. So you can read a book about what it's like to be an African American. However, you will never truly know that experience unless you are an African American yourself. However, you can become very well versed in an entire community or identity or group and somewhat get a idealization of what they have experienced. And basically, cultural competence is a one-time checkbox, as we said on the other slide. Cultural humility, however, is more like a lifelong learning situation and really thinking about the assumptions that you personally make or carry. We all have some level of prejudice somewhere in our minds. However, it's how we choose to identify and recognize what these prejudices and discriminations are in our head that we carry. And in our role as an anesthesia provider, it's equally important to recognize the power that you have in the dynamic. After all, we are technically a adjunct to the patient while they are asleep. And nothing is more overwhelming than to feel somebody's going to have complete control over your body when you already are distrustful of the system, and to have somebody take over full will is very scary. Now, these power dynamics, they exist everywhere. Right now, I have the power as the presenter, but I'm not the expert at all of this, on all of it. Others watching this presentations are maybe more likely more well informed than I am. So it's a way of me saying, I don't know everything, but I'm willing to learn. And that's what cultural humility is. And that's how we need to approach our patients in all situations, to be honest, regardless of gender identity. Another tenet to the commitment is institutional accountability. Now, many hospitals, licensing agencies, and anesthesia groups host these talks, and I see that is accountability holding its members to improvement. And each of us can go back to our organizations and explore ways in which we can become more accountable for our actions and things that we maybe witness that we don't realize that we do, but always be aware that you are a power dynamic that needs to be willing to grow. And I hope that we can hold on to this framework as like continuous lifelong learners with critical self-reflection in both the clinical setting as well as in our personal lives. So how can we essentially be able to provide gender-affirming care if we already have organizational barriers that be able to prevent us from being able to move forward? Well, we have to look at undoing the harm. This is going to be able to create a welcoming environment in which we accept everybody, providing bathrooms in which all genders feel accepted and welcome and not isolated off to one particular bathroom or not. So it's best to make them all gendered bathrooms. Printed forms that we give out for discharge instructions and preoperative material, they need to be printed in affirming language. We need to remind ourselves of the customer service etiquette that we have and how we address our patients. We need to be respectful of pronouns. And of course, this is the one that is being a little bit more challenging because at our facility, we are supposed to include the gender identity pronouns in our EMR. However, a lot of the admission staff has not been including that in the EMR. And so it makes it difficult for us when we have a patient, particularly one that's there for gender affirming procedures in the first place, to be able to have that intraoperative dialogue in which we have to ask them, well, how do you wish to be called? The other thing is, as a provider, you need to be open to feedback. So if you say something wrong, just apologize for the misstep and move on and try to be more open-minded and continue to use an affirming language that they wish to be addressed. Another great way is visible inclusion. And this is where we have people actually part of our staff who are members of all communities, backgrounds, races, and gender identities as well. Visible inclusion is probably the strongest form of saying that we accept you as an individual because we have accepted somebody into our staff as a welcoming provider. Someone may actually come into your office with one attitude or an outward presentation and really think about everything that could happen to a person leading up to and following their visit with you, depending on where you are in the process of being seen. Are you the care provider, the receptionist, the lab tech? What tools do you have in place to train the staff, to greet people, to affirm inclusivity? Where do you count on visuals or language on forms? At the end of the day, this is so much more than about someone's sexuality and behavior. It's about how we signal to our clients and communities that we see them and affirm to who they are as humans. Also, with gender affirming care, always ask for consent first. Frame why you're asking something and be transparent Ask for consent. By using open-ended questions, it allows you to say, this is why I'm asking this question in reference to your gender transition surgery or gender transition care. We saw that on the survey from the transgender survey performed back in 2020 that a lot of people felt that they were seeking treatment for diabetes or cardiac health, and they felt offended because they were being asked more about their transition rather than about the reason they were actually in the office. However, it may be important to us. We may need to know what type of hormonal treatments they are on, and that may impact other systems in their body. And if we say that and explain why we do it, it allows us to be able to gain their confidence that we are not just assuming that their hormones is why they're there seeking treatment. We want to know why and what their past medical history is there before they get there for their other health issues as well. And of course, to quote Dr. Holt, don't assume and don't yuck my yum. And don't assume anything about gender. Just because a male may dress more in feminine attire, it does not necessarily mean that they identify as a woman or maybe that they are gay. Don't assume that just because a man that is dressed as a female or wearing more feminine clothing is naturally what their homosexual status would be. Don't assume what the relationship status is, because you never know who that person is there with them. Is it somebody that they love? Is it somebody there that's just for emotional support? A lot of our older transgender population have actually been married before and have children and may still be married, and you don't understand or know what their situation is necessarily. So the best thing to do is, if you have to ask questions of this, make sure and let that person know that there's no judgment and you're simply just trying to get things in context of where they are coming from. And of course, as I said, Dr. Holt says, don't yuck my yum, meaning what may be pleasurable or exciting to one person may turn another person off. And those expressions that you have are very judgmental when it comes across to somebody who doesn't consider it to be inappropriate. So also, you want to be able to ask this pretty consistently throughout all your patient clientele that's there so that you stay within a regular format. And you need to let the patient describe their position and their journey of transition. Not all trans people talk about the parts the same way, and don't all use or don't use our parts. Give them room to say why they are there and what they are concerned about. And it's very okay to ask how they describe their parts. So definitely let them have an open-ended conversation and slow down during the interview process with them. So in conclusion, we have opportunities to be able to fill the gap. And this is where we're going to try to be better. And this is where we look at what are institutional barriers that are out there and try to find ways to be able to improve it so that we have more gender-affirming care. For instance, required data is often binary. When people check into the hospital, are you male or female? Basically, we need to create programs and let fewer barriers that don't fit people into a box. We need to advocate with our organization also to provide more gender-affirming care. And then we need to be very transparent in what information we actually need to obtain from our patients. And of course, we need prevention language and recommendations as well, such as the terminology that we went over earlier in this program. We want to make sure that our public health campaigns are more inclusive. And then if you think about it, some of the printed forms that we have, visuals, language, and the research, it's not about the persons who are transgender or non-binary, so it doesn't affect them and they feel like they are left out. And of course, never assume when you see a patient, or never assume that what we do doesn't have implications that have other ripple effects as well. Treat people as they want to be treated, and remember that the majority of LGBTQ plus individuals are more than just what their risks are. Okay, now here are the 3 additional resources that I have regarding gender affirming care with transgender and non-binary persons. And you'll see the trans line and also the Center of Excellence Transgender Health from the University of California, San Francisco, and also the Fenway LGBTQ Health Education. And these are great resources to be able to help you be able to provide gender affirming care if you had any questions. And of course, feel free to reach out to your coworkers as well, and including myself, because even though I am not the ultimate expert on this by any means, I can at least provide a little bit of insight as to maybe how we wish to be able to treat and move forward with our patients here. Over the next few years, I plan on working a little bit more with the administration to try to get more gender affirming care questions that we initially started doing better about when we started doing gender affirming procedures, and for some reason they have fallen to the wayside. And finally, the last slide will include my references, and I look forward to working with you guys a lot more in the future. And always be humble, and remember that everybody is fighting their own battle out there, and it's best for us just not to judge and try to just be respectful of the journey that everybody is on.